I'm Brenda Wong, Chief Medical Advisor for CureDuchenne, retired from clinical practice just early this year after 45 years, 20 years in pediatrics and 25 years in peds neuromuscular, and a solid 8 years just with my families and patients with Duchenne muscular dystrophy and Becker muscular dystrophy. So that's why I'm standing here talking about nutrition rather than just a neuromuscular topic. And for this panel session, what's this? You can see my age. No, I'm not the digital age.
Brenda, that's Brenda.
Oh, okay, that's what it does. Okay, give my age away. Okay, all right. So, and with this session, we have our panel speakers, Dr. Tiffany Garcia, Doctor of Clinical Science and Nutrition, and as well as none other than Hawken Miller, the patient, adult with Duchenne muscular dystrophy, who is an example of what we can do with this nutritional topic every day in our lives. So for this first part, I will kick off with an outline. And, you know, as we age, we get more complex medical issues and we lose muscle. So I think of that as what's happening in our boys and patients, but at an earlier stage than us losing muscle starting from age 30s and 40s and health issues. So I like this approach to consider nutrition from the domains of the clinical aspects. So I will cover the clinical background and a framework for nutritional needs in Duchenne muscular dystrophy. And Dr. Garcia, Tiffany, will give you the meat of the food aspect. And here we have Hawken to really be giving us a practical application and what we can do. So hopefully we can cover all that and then open up for a question time. Why are we talking about nutrition? Here we are, cutting edge medicine, gene therapy, and nutrition is just a mundane topic. But remember, we always say you build your foundation, a foundation of rock, to build your skyscraper. And nutrition is part of it, of lifestyle medicine, where you eat well, sleep well, breathe well, live well, and move well. So this is part of what we need in order to build your foundation of the basics for optimal health for us to benefit from all the new drugs that we have. Overnutrition results in damaging effects on glucose metabolism, on cardiac and pulmonary function, and motor mobility and motor dysfunction. So you can see how it's connected to the whole patient. We treat the patient with Duchenne muscular dystrophy, and we do not just treat Duchenne muscular dystrophy. And that one patient has all the entire systems to consider, and you can see nutrition impacting the many systems that you can see on this slide here: cardiac, pulmonary, endocrine for metabolic, as well as GI, urinary system because of dehydration, fluids, cardiorenal syndrome, and you would have osteoporosis, skeletal. So it is critical, it's foundational for optimal health, and that's why we are including it in this meeting this year. I'm going to walk through just the highlights in terms of, through the Duchenne lens, the nuances of nutrition that is peculiar to Duchenne's that the general practitioner may not think about. And I think we want to think about addressing the problems and the plans and care recommendations on the various stages of DMD. The needs are a little different, and the approach will be really proactive, when you're talking about the newborns and the early stage. And then when we reach the late childhood and early adolescence, we may start seeing the nutritional issues of overnutrition at this stage and the metabolic issues, and that would require treatment and intervention. And then when we are now having more of our adult patients reaching the 30s and 40s, it's a new set of problems altogether. So basically, you can actually kind of like divide it under these categories and hone in. And again, it's back to personalized medicine on a personalized program that you can advise on. Now, the topics that I think we think about is growth, and a lot of people talk about it as weight, but I like to think about it as a body composition. And basically, we talk about the definition of overnutrition. In the lay population, they use the word obesity, but because that's based on the criteria of BMI, right? And anybody with a BMI of adults, 25, and for kids, 85th percentile is overweight. Anybody with a BMI of greater than 30, and for the pediatrics, a percentile BMI of 95th percentile, they use the term obesity. But if you remember, even just Duchenne patients without steroids, they're shorter, right? So BMI is weight over height squared. So if your height, you square that, your BMI goes down. So if our Duchenne patients are shorter and exacerbated by steroids, then basically your BMI goes up. So it's not that great a definition. So I tend to go by lean muscle mass or percent fat based on the body composition that we already routinely do for our DEXAs as part of our bone health follow-up. So if you could see here that the weight, this is a recent article, 2022, and you still naive, you can see this red line here. That is the weight standard deviation, 0, so average will be +2, -2 standard deviations. You can see that if they are on intermittent steroids, which they think that they will have less of a weight gain. You see this blue line here? Actually, the intermittent steroids, you still have that weight gain over and above the naive, steroid naive group. And the daily deflazacort and intermittent deflazacort, you can see the green, the orange line here with the, this is prednisone that's daily, and it's the green line. So you can see that the weight changes together with the height change that is greater with daily deflazacort, then pushes your BMIs up. So I think we could review this in detail if you're interested, but this is just, oh, sorry, I'm supposed to turn the laser off and not point it at the screen. Okay. I'm not of the digital age, okay. The second thing, just in the interest of time, I need to have time for my speakers, so I'm just going to kind of go through the slides, not as in detail, but just to highlight. The height, which everybody is worried about because of the growth suppression, is an issue that results in like intermittent steroid dosing, as well as Valmoron. And the discussion about the advantages of height growth versus a shorter height and its impact on motor function is something that's kind of trace back to even before the steroid era. If you look at this article from Brazil, 1988, these are steroid-naive patients. And they showed that when height was adjusted for patients' age, there was a statistically significant correlation between height and clinical costs, meaning that those with shorter height has got actually a better clinical cost. Smaller boys have a better clinical cost than taller patients. And do you know that that actually, from that study, resulted in the CIDD first trial of the growth hormone antagonist, because they thought it was related to the growth hormone absence that resulted like in better function. So they did a Mazindal study, but that was negative and that was dropped. So now we know that, remember your formula, BMI, weight over height squared? So if you have lean muscle mass, that is the driver of your motor function, divided by height squared, your lean muscle mass, the taller you are, you square that height. What happens to that ratio of lean mass over height squared? It goes down, right? So your lean mass index goes down. And technically, if you've got the amount of muscle that's spread across a longer bone, it's a mechanical disadvantage. And that does explain why there is a relationship between height and motor function. So we look into our DEXA data, and you can see that compared to healthy boys, and this red line is the Becker patients, pediatric age group, normal motor function. This green line is the Duchenne patients, and we can see that our Duchenne patients have lower lean mass. This is total. This is the index, which is accounted for by dividing by height squared. At about age 12 or so, it becomes static. You really don't increase any more muscle, unlike the Becker patients who are normal. So you can see the appendicular lean mass index, which is the muscles in your arms and legs, over height squared, they start to drop. And if you compare the Beckers versus the Duchennes, this is a group of Beckers with normal motor function. So if you can maintain your muscle mass, you get normal motor function. Now, this is the Duchennes, this is the index, this is the actual total amount. By the time they're about 12 or 13, that's also when we start seeing them lose ambulation. So really, this is proof that your muscle mass in your arms and legs is a key driver of your motor function. So what we did is also to correlate that with motor function with the North Star and predict it. And you can see that this is the predicted motor function in terms of North Star, and the cluster here are those with higher lean muscle mass index scores compared to the cluster that's here. So I think this does kind of make us think about you should monitor your height growth closely. First of all, I shouldn't point the laser at you guys. Yeah, you should monitor your height growth closely if you are on intermittent steroids or you are on Valmoreron, because first of all, it dings your index and brings your mass down, because the other one is contractures, because with the pubertal growth between 10 and 12, the rapid development of ankle contractures, you can actually lose ambulation. So a picture is worth 1,000 words, so I thought I would show and share the beautiful color pictures that we actually use with our teenagers who's 12 and 13 when it comes to a discussion on the rationale of our nutritional recommendations and the rationale of doing what we do. So this is a DEXA body composition. Tell the boys, you see the blue, it's all bones, so they can take their calcium and vitamin D and have strong bones. Now, the red is lean muscle mass. The yellow, not so much in a 5-year-old, but you can see the yellow is fat tissue. So the boys can actually visualize that if they keep on putting on weight, the yellow portion keeps getting more evident, especially around the abdomen. And this 5-year-old has mainly red, right? He's got a nice, you cannot see, but the ALMI is in a good number for a 5-year-old at 4 point something. For the typical Duchenne's that is 11 to early teens, if you have an ALMI that is below 4, 3 point something, you're non-ambulatory because there's less muscle. If you're in the 4s, you are ambulatory. And this one is a patient who's 11, has been pretty stable. And you can actually also see that in the graphs here. The blue is lean muscle mass. This is fat mass. I showed this one particular because a very informative family, very well-informed family. And when we discuss at age of 5, the dietary guidelines that we like, no excessive calories for the amount that's needed for the 5-year-old, no excessive carbohydrates, and the good type of carbohydrates that is, high fiber and low glycemic index, and watch the proteins. We see that he actually lost % fat, and that's in a 5-year-old. So we can use this to track the changes they make in their daily diet. This is one where also you can see the lean muscle mass is pretty stable and his motor function has been pretty stable. And this is, again, a change in the trajectory of the fat mass. So this is actually pretty useful in clinic when we kind of explain to the patients, hey, how are you doing? And they get really motivated when they see that fat mass comes down and their lean mass remains stable. Now, this is to show that at age 20, when there's 55% fat mass, you've got less muscle left. You can hardly see the red, and it's all yellow. So I think this one, we're worried, even if your weight number looks good, but if you have got 55% fat, you have sarcopenic obesity and that makes us think about looking out for metabolic dysfunction that you're familiar with in the adults. And as in contrast, this is our Becker patient who is 44 years old, a deletion 49 to 51, a almost normal North Star who couldn't qualify for the HY study, North Star of 33, and look at his ALMI, 7.6. Regular people, adults, will probably be 7, 8, 9 for the males, and he's really in the normal range at 7. Our ambulatory Duchenne's ALMIs in the 4s. If I see an ALMI like 5 point something, that usually, for the younger group, about early teens, that's usually the intermediates. So I think with this, you think about body composition, than just a weight with a number itself. So through the Duchenne lens then, we really need to consider what is your energy requirement. And one note about patients with less muscle is that we may need less calories than usual. So the concept of how many calories you need is really the resting energy expenditure, the amount of energy needed to maintain metabolically active components of fat-free mass, and that's the liver with 20% of it, and the muscle is 20% of it, and then the brain. So if you've got less muscle, you've got the lower energy requirement here. So I think we still haven't come up with what exactly is the resting energy expenditure of the early ambulatory, late ambulatory, non-ambulatory, to calculate on a personalized way what is their requirement. So again, there's work to be done for that. And the other pointer is that when we are non-ambulatory, you see, REE is about 60 to 70% of total energy requirement. The rest of it, that 30% to 40% is from your activities. So if we are not burning up energy to walk or to move around, then your requirement goes down. So I think there needs to be a personalized kind of approach to checking how much one needs. So really quickly, the other one that you got to think about is there's ongoing muscle atrophy. And so repair is needed and maintenance. And so for our patients, we actually bumped up the protein intake from the 1 gram per kilo per day to 1.5. And actually, that 1.5 is now what's recommended by the USDA, January 2016, to everybody. So they upped the protein intake in the latest USDA guidelines. So I think that 1.5 is what we had been doing, and that's when you see our patients actually have that change in our body composition. So that is another pointer to remember. And then sodium intake is important, and I want to just highlight a little bit that we're not advising a low sodium diet. We're advising a normal sodium diet that is 1,500 milligrams of sodium per day for pediatrics, and for adults with, on hypertension or, that kind of, regular adults, is 2,400 milligrams a day. We are taking much more than that. My ramen noodles is 2,700 one packet. So I think be very careful. We are not asking you to take low sodium, but we got to do the right intake. And there were a lot of our patients that come to us and said, look, usually it's our patients who's non-ambulatory. They've got this swelling in the feet that we don't have heart failure, we don't have low protein levels, we don't have GI losses of protein. And it's really the sodium intake. And they had like a week of fast food. And so I think, yeah, look out for that. And then calcium, just a note, is that because of the osteoporosis, there's a little bit more addition of 200 milligrams extra per day, greater than what Tiffany will show you for the whole table. And then fluid intake is really important for preventing constipation in the younger ones, but the older patients, you really need to avoid your kidney stones by adequate hydration. Water is the best drink ever. We usually have young families coming, we train them to drink water, and that was great to see them come in. They're very proud to show me their water bottle when they come to clinic. Yes, and then fluid intake, I think, becomes a problem when in our older population, because when you're on a tube feed, like in the 40s, any tweaks in your feeds will always mess up your electrolytes, and that electrolytes will mess up your potassium and the cardiac rhythm and so on and so forth. So basically, these are the pointers to remember. Now, this is a busy slide, but I just want to highlight the fact that we've got to think about, actually in the Duchenne muscle, there is metabolic dysfunction independent of steroids. You look into the literature, and you can see that these are articles that mention and found insulin resistance and obesity, metabolic aberrations in Duchenne patients independent of steroids. You have also the prevalence of the overnutrition problem that we have. Now, here in this series about 5 to 19-year-olds, obesity as defined by BMI, it's like 28%. But that's not much different from what's happening right now. The latest numbers for our US population, 20% of pediatric patients aged 2 to 18 are obese. 40% of our adults are obese. So you still see that in our population, but a little higher. However, you can see that you have got lipid problems already, and hence, we just need to be more alert to the problems that we may encounter as a result of these metabolic derangements. This is actually documentation of impaired glucose tolerance in 19 to 34-year-old patients, the older patients, where you can see half of them meet criteria for impaired glucose tolerance, meaning they're not diabetic yet. But if you give them a load of glucose of 75 grams, they're going to have higher than normal expected glucose levels, and 13% with type 2 diabetes. That's usually metabolic because some populations are more at risk for diabetes. It's all your genetics again. So we have families where they work hard on the diet and everything, but because of the family history of type 2 diabetes, we see more difficulty in that weight management. And then here you're going to see what happens when you have an overnutrition state and obesity, that it flows out later with impact on the fatty liver. And you know that now in our general population, because of the 40% obesity problem, we are seeing fatty liver with the risk for cirrhosis and liver cancer. And liver cancer is going up at the rates because of this factor of the fatty liver issue. So again, I think we want to think about, like, as our patients grow older, we're going to encounter the adult problems, the lipid problems that is on the heart, and think about that, project that, and then mitigate that now. And you can see that there was an article that was interesting that talked about the role of insulin resistance in Duchenne cardiomyopathy. In MRI for our Duchenne patients, your LGE, your fibrosis, is epicardial, right? Subepicardial. And here they're looking at subendocardial, and that is what they see in the metabolic patients that has got all the heart, ischemic heart, because I think that's where they get ischemia. So I think this is an interesting article for us to follow up with our cardiac colleagues in following our older patients with overnutrition and metabolic problems. And then you can see the fact that the Duchenne's itself, they did a review article, and their conclusion was that insulin resistance interacts with dystrophin deficiency and itself may impact the progression of DMD. So I think this is food for thought and for research as well, to really think about the role of insulin resistance in just DMD. And that is the basis for the metformin study in Switzerland to treat Duchenne's because of its relationship with this AMPK signaling involved in muscle function. So that's just a slide for us to keep prodding on to the next frontier. And what is insulin resistance? I think if you're in my clinic, you probably would have heard more of this, but let me quickly just kind of highlight this. So when you take carbohydrates, and especially ready-made glucose, like my 39 grams of sugar in my can of pop yesterday, you then kind of get an insulin surge to try to control that glucose spike so that it's normal and that it's not in the diabetic range. And insulin's role is to deliver your glucose into your cells at the receptor level. So what's happening is that when you have a spike, you have high insulin levels, and over time, you get insulin resistance, where the receptor will say the doors are kind of a little shut, and it would not deliver the glucose into cells. Now, muscle cells and brain cells and heart cells need glucose as a form of energy to function. And so what happens is that with the high insulin levels that is needed to push it in, initially it will get but at the expense of high insulin levels. So you won't be diabetic, your glucose levels will look good. So that's the precursor, stage 1, before you get into pre-diabetes, where I give you a load of glucose and then you get high glucose levels. And then finally, type 2 diabetes. So I think most of us, like middle-aged people, where you start getting that muffin top, we do have that same problem. I do have that same problem. And so it is a state of insulin resistance. That's what we mean. And basically, we need to address this insulin resistant state before we get to the pre-diabetes, before we get to type 2 diabetes. In my clinic, we get a lot of insulin resistance with the high insulin levels in the fasting state. And if you do an OGTT, you probably will pick up more. But the second stage, the pre-diabetes, where the glucose gets abnormal when you load them, probably lesser in number, but I had about a couple of type 2 diabetes. So not that common yet, but again, a very proactive approach. We want to stop it before the lights turn red. So again, be proactive and know your projected trajectory of problems and intervene early. But if we already have that problem, don't be in despair, yet we can work around it. And in my clinic, my patients have been fantastic. They have shown to me how they were able to maintain their weight, or they have, I said, honey, I shrank the kid, you know. All right, bone health real quick. Now, bone health, you have steroid-induced osteoporosis that affects trabeculated bone in your spine, and that's why you look out for spine compression fractures. But from the Duchenne lens itself, the breaks that you get in your fractures is a lot related to the Duchenne muscle weakness with the decreased muscle-bone crosstalk. So here you're seeing a Becker patient that's only like 5 years old, is that right? He's very young. And you can see his femur is bigger in diameter than my Duchenne patient that is Z20. And now he's 5, and if he's 20, his weight, say about 40, 50 kilos. If he falls, this little stick will break. It's fragile because it's a small little stick as opposed to a stronger stick, right? A bigger stick. This is a Becker's of the same age, and you can see the difference in the bone density. So the part about osteoporosis is if we can improve muscle strength, you will also improve your bone health. As we said, the RDA, the requirement for calcium intake, you think about additional 200 milligrams and based on the age group. Now, vitamin deficiency is very, very common. When we look at our about 288 patients in the past, we found like 90% of our patients with vitamin deficiency or insufficiency. About 55% is deficient, a very much lower level that is less than 20. And the insufficient is 20 to 30. Normal, 30 to some labs are 60, some are 80, some are 100, but a sweet spot that we aim for is 40s because that's what they do for the menopausal women, and that's what we follow to get it to the low 40s. And you got to monitor for renal stones. So if you don't drink water, and if you have no monitoring with levels hitting 60, 70, 80, you will be at risk of kidney stones. So you always need to monitor the level and monitor your urine for hypocalciuria. And then, of course, there is the treatment for bone health that our endo colleague, Dr. Weber, will be covering after this session. Last but not least, dental. Actually, the Europeans actually have reported like dental abnormalities. In clinic, you know, I look at your mouth and your teeth, and trying to make sure that we have no issues with the bite. Because if you have got malocclusion, especially with the posterior bite, you're not going to chew well when your muscles fatigue. And then we also have a few patients that will develop contractures of your oral muscles, and the older adults right now, some of them have limited oral aperture openings. So I think that's something to consider, and the side effect of our treatment for osteoporosis, the IV form of bisphosphonates, with the risk of jawbone death or osteonecrosis, is related to also like dental implants, dental extractions. So from young, make sure you've got good dental hygiene and monitoring. I found that a number of our teenage boys don't brush their teeth. And it's real, and they still won't brush their teeth. So I think that's something that through the Duchenne lens, you can start early. Dr. Tiffany will cover the supplements, but I would just caution that, you know, in our clinic, if we're not able to monitor safely, it's not safe to just dose blindly. So we kind of tend to limit to our calcium supplements only if you have inadequate daily calcium intake, so you really need to calculate what you're taking from your diet. And as mentioned about vitamin D monitoring just now. And then in our clinic, we are able to monitor CoQ10 levels. There is a paper out from WashU that showed low CoQ10 levels in muscle for patients with muscular dystrophy compared to healthy adults, and the aging people kind of low too. So I think and mitochondrial dysfunction, secondary mitochondrial dysfunction is what we see in chronic disorders like ALS, SMA, DMD. So, and also our blood levels of our CoQ10 in Duchenne's, the mean level is lower than the mean of the population. So that is the reason why we are using that. That's evidence for the labs that were lower. And we really caution with the use of other supplements that you should monitor closely with your providers. So right now, I'll segue now to Dr. Tiffany Garcia to talk about food. And I like this, that Hippocrates did say, to think about, let food be thy medicine. In food, excellent medicine can be found. In food, bad medicine can be found. So the food you eat can either be the safest and most powerful form of medicine or the slowest form of poison. So I think just as food for thought, and we next will hand this over. Do you need this?
I had to need the pointer.
Yeah, I think I've been dangerous. I've been putting...
Thank you. All right, thank you, Dr. Ron. All right, you guys got all the scientific background. Now we're going to talk about the fun stuff, food, and how to actually apply this. We're going to be covering a lot of stuff that Dr. Wong already talked about, but clinical application. How do you actually bring this material home with your children? So a little bit background about me. So Tiffany, Doctor of Clinical Nutrition and Functional Medicine. So I work in what's called medical nutritional therapy. So I work with patients to help improve chronic conditions and chronic illnesses to improve life outcomes and just quality of life. And this is my nephew, Odin. So he's right back here. We have been coming to these conferences for, I think, about 5 years, and really started getting involved in the community. And then I've been involved in his care and just helping him, you know, figure out what is the most nutrient-dense food for him and what's the best diet protocol for children with this condition. And we've been having a lot of fun making cooking videos. So one thing I noticed is as he's getting older and he's gaining independence, he wants to get involved more in making his own food, preparing his own food. So how can we do that safely without him burning down the house using an air fryer? So if you want to watch our videos, we have them on YouTube. They've been a lot of fun. And then I also want to think about when we talk about nutrition, it's not about perfection. It's just about what little improvements can we make every single day. And there's going to be a lot of failures. So there's some studies that show that you have to reintroduce a food up to 15 times before a child will actually accept that. But there's also studies that show that your efforts are not wasted. if you introduce these foods when they're young, they're more likely to try these foods as they get older. So I've seen that with my nephew, is that he was very, very picky when he was younger, and as he's gotten older, he's tried things like calamari. Like, who knew that he was going to try some kind of fish, you know? So their interest will grow, and your efforts will definitely help improve them along the way. So, all right, so what are our overall nutrition goals? So we want to protect that lean body mass. That lean body mass is muscle and bone mass, that critical tissue that helps support overall health for these children. So as Dr. Wong explained, is that we're getting a decrease in muscle mass, and that is going to be replaced with fat mass. So how can we slow down the acceleration of muscle and bone loss with dietary recommendations? Another thing we want to do is we want to protect metabolic health. So balanced blood sugar, blood lipid panels to help prevent things like hypertension, and then also diabetes as well too. So we'll learn some practical ways of doing that as well too. And then another thing we want to do is help support digestion. So with a decrease in ambulatory and movement can also come constipation, abdominal pain, other complications as well too. Medications can sometimes induce things like constipation, abdominal pain. So how can we help improve that with dietary recommendations? And then another thing that we can do with the guidance of a practitioner or a dietitian is correct for vitamin and mineral deficiencies. Okay, so what are some specific needs? So when we think about calories, I don't want you to think about so much a number. I want you to think about nutrient-dense foods, because this is an estimate, but it depends on the individual and depends on their current level of physical activity and their ambulatory state. So instead, I want you to think about food first, nutrient-dense foods, and then monitoring weight trends over time to establish what is the appropriate calorie intake for your child or for the individual with DMD. However, we do know that protein is extremely important. So as muscle is being broken down at a higher acceleration, we need to replace protein amino acids. So proteins are broken down into amino acids. Amino acids are used to replace pretty much every tissue in the body, but specifically muscle and bone. So there is an increased need, so anywhere from 1.6 to 2.0 per kilograms of body weight. So take the individual's body weight, divide that by 2.2, and then times that between 1.6 and 2.0. That can seem like a lot of protein. However, this is also going to help with improving satiety and helping with that energy balance that we talked about. As appetite increases, possibly with steroid use, ambulatory and physical movement decreases, and so they're not burning as many calories. So how can we help manage hunger and improve satiety? You can increase protein intake. Some good sources of protein are going to be things like poultry, chicken, turkey, duck. Pretty much think about animal-based products, minimally processed, and then there's also plant-based products like tofu, tempeh, and peas. All right, so what are some specific vitamin needs? So again, I want you to think about food first. A lot of people, when they think about nutrition, they want to rush to supplementation. Well, we should not be supplementing until we know the individual's specific needs, because we want to make sure that we're not overdoing it with supplementation that we can cause complications, but we also want to make sure when we're supplementing that we're actually giving them the adequate amount that they need. So as we mentioned, vitamin D is a very critical component for muscle health and bone health. However, if you're not testing vitamin D levels, you're not going to know how much that individual is going to need specifically for vitamin D. Vitamin D is one of those nutrients that it's very low in food-based products, and a lot of these individuals are not going outside a lot, not getting a lot of sun exposure, so it is very common to have low levels of vitamin D. However, vitamin D is what we call a fat-soluble vitamin, so it will be stored in the body over time, which means that you can reach toxicity levels. So we want to make sure that we test, we supplement, and then we retest. So that's why it's very important to work with a practitioner or a dietitian that you can go ahead and do this so you're not overdoing supplementation. And then we have things like selenium, potassium, magnesium, and zinc. Okay, so what foods do we want to increase? We want to increase foods that are called antioxidants. So our body produces free radicals. Free radicals is a normal thing that everyone's body produces, and it causes inflammation in the body. So think about it when you're starting a fire and you put wood on the fire creates smoke. That smoke is the free radical damage that's going on throughout our body. However, we can put that smoke out and we can reduce that inflammation by adding antioxidants into our diet. Antioxidants, think about colorful fruits and vegetables. Every single color is a different type of antioxidant. So how we increase the antioxidant intake is we increase colorful fruits, vegetables, things like real cocoa or real chocolate, and then herbs and spices, nuts and seeds, And then again, we want to focus on complete proteins. So what is a complete protein? A complete protein means that it contains all 9 essential amino acids. So there are 9 amino acids that we cannot make in the body that we have to get from our diet. A complete protein is going to be an animal-based protein. Plant-based proteins typically are what's considered an incomplete protein, so they're missing 1 or 2 amino acids. However, that doesn't mean that if you have more plant-based protein that it's a waste. Our bodies are smart. If it gets an incomplete protein earlier that day, let's say beans, and then it gets another incomplete protein, let's say rice, later in the day, it will hold on to those amino acids and then use them together to create a complete protein. So, however, when we think about complete proteins, those animal-based proteins are going to have a much higher percentage of protein per other macronutrient ratios. Then we want to think about complex carbohydrates. So these are going to be carbohydrates that we found naturally occurring in nature. So you want to think about your fruits, your vegetables, but also things like your potatoes, your rices, your whole wheats. So think about carbohydrates as if they are a single ingredient, they're found in nature, they're probably good. They're going to contain fiber, they're going to contain vitamins and minerals, and they're going to contain those antioxidants. And then we want to say healthy fats. So there has been tracked lower levels of healthy fats in patients with DMD. So we really want to focus on increasing healthy fats that help support brain function and helps control energy metabolism. That's going to be found in things like avocado oil, avocados, olives, olive oil. Also can be found in things like nuts and seeds, fatty fish like salmon, and then also grass-fed meats, chia seeds, and flax seeds. Okay, so some foods that we want to reduce. So this is the one that makes everyone sad because these are typically some of our favorite foods. So refined sugars. So refined sugars are things that are added into foods to make them taste sweeter, make them taste more desirable, typically found in things like soft drinks, juices, cookies, candies, those typical things. But they're also in more uncommon products that you might not think of, like ketchup, for example. There's a lot of added sugar in ketchup and dressings. So this is where you really want to just turn that food label over and look at that food label and look at added sugars. If it just says sugars, that could be the naturally occurring sugars in the food, but you want to look at is where it says added sugars. So we really want to try to minimize that to no more than 30 grams per day. So this is going to go with when we're talking about insulin resistance and balancing blood sugar and helping prevent things like diabetes. Really trying to minimize those refined sugars can help improve that. Then we want to think about reducing processed snack foods. And one of the main reasons for this being is processed snack foods, one, are more likely to make you overeat. So it's really easy to eat a whole bag of potato chips in one sitting and then still be hungry for something more. So we know that those foods make it easier to overconsume calories, which can equal to more weight gain. So those foods also contain a lot of sodium. So as we were talking about, we want to make sure that we are just getting an adequate amount of sodium and not overdoing it with sodium. So in America, 70% of our sodium intake actually comes from processed food and not the sodium or the salt that we're actually putting on our food. So we can greatly reduce our sodium intake if we just reduce processed food consumption. That also includes things like frozen meals, canned goods, and sometimes frozen fruits and vegetables as well too. So again, something that we need to do is just turn over that food label, look at it, and see if there's any additives in those food labels. Another one we want to try to reduce is processed meats. So these are the things like hot dogs, sausages, bacon, also things like fried meats as well in fast food. So think about if it is like a candied or it's a fried food, what that does is it increases what we call AGEs. So these are end glycation end products that actually increase inflammation in the body. So we already have an increase of inflammation from rapid muscle breakdown. We want to try to mitigate that. So if we can just go for more unprocessed meats like cold cuts and things like that, and if we can also focus on broiling, baking, and air frying our meats versus frying, we can really reduce those AGEs in our meat products. Okay, so when we're talking about balancing blood sugar, so this is really cool. So when we're talking about balancing blood sugar, we're talking about the glycemic index. So each food has a different level of glycemic index. There's high glycemic index foods, which are more common, things like the sodas, but there's also things like a ripe banana or watermelon or a sweet potato. Those are considered high glycemic foods. And what that means is that when you consume that food, your blood sugar is going to rise and then it's going to drop rapidly. And your body can try to overcorrect for this, and that can cause things like insulin resistance and other complications. But there's a lot of things that we can do to help just balance our glycemic index, even if we do enjoy those foods. So for example, if you want a cookie, if we just eat protein before we eat that cookie, like let's say we eat a piece of chicken before we eat that cookie, we'll actually reduce our glycemic response from that cookie. So so we can still enjoy some of those sweet treats, but better balance our blood sugar. There's also other things that we can do, is the way that we cook our foods. So for example, if we cook a sweet potato and we get it out of the oven, it's piping hot, it's gonna have a very high glycemic index. But if we wait till that sweet potato cools, it actually lowers its glycemic index and increases what's called resistant starches, which resistant starches are really good for our gut. Same with like rice. We know that if we cook rice, let it cool, it's gonna have a significantly lower glycemic index. So there's a lot of practical things that we can do where we can still enjoy the foods that we love, but we can also balance our blood sugar. So first, we want to try to just eat low glycemic foods as often as possible if we can, so avoid those ones that we don't necessarily need. But then also, let's make sure that we eat our protein first, so order of operations, protein before the high glycemic foods. The other thing that we can do is we want to make sure that we let our food cool before we eat it, and make sure that we balance our blood sugar that way. Okay, so nutraceuticals. So again, these ones I want to talk about from whole foods first before we think about supplementation. So glutathione is what we consider our master antioxidant. So this is a really great nutraceutical that helps reduce inflammation. This one is going to help protect those cells from that oxidative damage, and it can be found in things like Brussels sprouts, broccoli, kale, cabbage, asparagus, avocado, okra, and spinach. Then we have BCAAs. So BCAAs are amino acids. So this is a branched chain amino acid that elicits the most protein synthesis or helps preserve muscle at the highest altitude, highest signal, essentially. So what this can be found in is animal-based products. So again, meats, dairies, and eggs. Also can be found in supplementation, but again, you want to make sure that you talk with your provider before you supplement with BCAAs. Creatine. Creatine monohydrate is one of the most well-studied supplements that we have, but we have shown that creatine can actually help improve muscular strength and help improve ambulatory, those individuals that are still ambulatory as well too, and reduce fatigue. Creatine is found in red meats, salmon, tuna, and pork. Also can be found in a supplement form, but again, making sure you talk with your provider about that. And then CoQ10, as we mentioned before, that is another one that we see in low in individuals with DMD that really can help support muscular health, but also cardiac health specifically as well too. Found in organ meats, fatty fish, pistachios, walnuts, spinach, and broccoli. Some more that we can find, probiotics. So think about fermented foods. So when we're talking about gut health, we want to talk about those gut bugs that we have. So these are these little bugs that hang out in our gut that do a lot of things for us. They help balance our blood sugar, help balance our blood lipids, help support our metabolic health. So we need to be re-inoculating those gut bugs into our body constantly to make sure that they thrive and the good ones survive. And that can be found in things like fermented yogurts, things like kimchi, sauerkraut, fermented foods, all really great sources of probiotics. Then there's bromelain. So bromelain is a nutraceutical commonly or most found in pineapple. So this one can actually act as an anti-inflammatory and work like a Tylenol or some kind of pain reliever. So bromelain is a really great one, special one that you can have help manage swelling, reduce pain, and promote wound healing, naturally found in pineapples. Then we have cinnamon. So cinnamon is really great at helping balance blood sugar. So if we just sprinkle a little bit of cinnamon onto food, let's say oatmeal, it can help reduce that blood glucose response from that meal. We have black cumin seed oil, which can be found in either an oil or in seeds, and that one can help support appetite. So if an increase in appetite and the kid feels ravenous, feels like they're having a hard time controlling their eating, black cumin seed can help with that. Then we have peppermint. So peppermint is something that can help support digestion, help reduce things like cramping, abdominal pain, and we can be drink in teas, help also support hydration. And then we have curcumin. So curcumin is the main active component that we find in turmeric, can help reduce muscle fibrosis and support preventing inflammation. All right, so we're gonna talk about gastrointestinal health real quick. So as I mentioned, constipation as a decrease in mobility, we are going to possibly get things like increased constipation or abdominal pain. So first we want to just talk about basic eating patterns that can help improve digestion. So making sure that we're sitting upright, making sure that we're taking time to thoroughly chew our food, make sure that we're actually chewing enough times before we swallow. And then we want to think about increasing fiber intake and fiber from whole foods, because when you get fiber from whole foods, you're getting soluble fiber that helps bind to things that we don't want in the body, and then insoluble fiber that helps push things through the body. However, if you have a low fiber intake, you don't want to just jump to a high fiber intake all of a sudden. We all know if we haven't had chili in a really long time and then we have it all of a sudden, sometimes it can make your stomach pretty upset. So we want to ease into the fiber intake. We want to stay well hydrated. That's going to help push things through. And then can we add in just a little bit of light movement after we eat versus just lying down? So if you're ambulatory, can we do some stretching? Can we do some light walking? For non-ambulatory, can we do things like leg lifts, torso twists, side bends? Can we do some massage in the digestive tract? And then can we also do some diaphragmatic breathing? All can help improve motility. So specific dietary recommendations: increase your fiber intake. Again, increase fiber intake slowly. Make sure that we cook or puree vegetables. That can help prevent the slowing down of digestion and constipation. Can we add things like probiotics? Kiwi is another great one that can help improve gastric emptying and enhance protein digestion. And then we have some other Ayurvedic ones like alma fruit that can help support digestion as well, and artichoke leaf extract. Okay, so some things that you can do easy to make sure that you just have some healthy swaps here is, so can we eat whole fruit instead of having fruit juice? So if we eat the whole fruit, then we're gonna get naturally occurring fibers in it that are gonna help balance blood sugar. Can we go for low sugar yogurts and other treats? So can we just read that food label and try to find things that have a lower sugar option or sugar-free option? Then can we also look for things like if there's lactose intolerance and you want to try to add dairy into the diet, can we go for things like aged and fermented dairy? So aged and fermented dairy is going to naturally have lower lactose, and the fermentation is going to help the body break down that excess lactose as well too. And then can we avoid buying things like chips and crackers? Can we actually make them at home, or can we buy ones that have simple ingredients? So again, turning that package over, buying the chips that have 3 ingredients versus buying the chips that have 20 ingredients. And then can we try to just cook at home more often? So if we're cooking at home more often, we're really controlling for things like added sodium, added sugar, and other food additives that just aren't helping out our overall health. All right, thank you.
Thank you. Thank you, Dr. Garcia. This one is the real deal of the whole panel here, since he has lived it out. So Hawken, I'll turn it over to you and share your experience and how you did it.
Yeah, well, thank you, Dr. Wong and Tiffany, just for sharing all that information. It may feel a bit overwhelming at times, but I think the biggest thing is just try to simplify it in your life as much as possible. And I can kind of talk about like my own trajectory with diet. I can start off, you might have heard this from my mom before, but she would make me eat a bowl of broccoli when I was growing up before I could eat the main meal. And I would cry, I would like try to get out of it. I would do all these things to avoid eating it. But I was so hungry and that was the only thing available to me. So that's how I got into eating vegetables, I guess. And so, that's something, sometimes you gotta be a little strict with it, but what you're doing with nutrition, I love the quote from that Dr. Wong shared, that food really is medicine, and how you treat it and your relationship with food can really impact just how you move forward, with Duchenne. And I think especially with the steroids, that weight gain can be a huge issue. And I know a lot of people struggle with that, and I think really the biggest thing is just really watching what you're eating and just making good decisions. So the way I look at it is, it's not like eating like vegetables like the whole rest of your life. It's making good decisions with the food that you're eating. So we know that digestion is a huge discrepancy for Duchenne, with sitting all the time. And so how you combat that is for me, it's trying to eat foods that are lower in carbs or better carbs for you, like talked about sweet potatoes, things like that. And so if I'm looking at my day, for example, if I have breakfast in the morning and it's like a breakfast sandwich and there's bread involved, then for lunch I wouldn't have a sandwich, because then that's a lot of bread, that's a lot of carbs to digest. And also really thinking about protein and vegetables as like your primary building block in your diet. When you're looking at your plate, it should be protein and vegetables in a very, very small amount, if not any carbs at all. Like growing up, my parents would just make fish and broccoli or chicken, and like asparagus or some kind of variation of that. And I think the biggest thing too is think about your portions and think about how much you're eating. Maybe try cutting what you're normally going to eat in half, eating that, just waiting a moment before you go on to the next part of it and seeing if you feel full or not. And I think that's a good rule of thumb, especially if you're eating out. The portions here are made for an average individual that doesn't have Duchenne, so just keep that in mind, that when you're eating out, when you're eating with your friends, like, you cannot eat the same amount of food that they're eating, and that's going to be detrimental to your health if you try to do the same thing. And so it's really kind of making those good decisions throughout the day to get your vegetables in, to get your fiber in, to get your fruits in, to get your protein in, and really focus on those things. And I know we just heard a lot of information and a lot of great information, but we can only do so much, and I don't want anyone to feel like any shame or anything for what they're eating, but just to think about how eating affects your body. And we know that with Duchenne, like, heart failure is a very, very serious concern that we have. And if you're eating too much and you're overweight, you're going to cause more pressure on your heart. You're going to cause more cardiac dysfunction than there already is. You know, we're already fighting one disease. We don't want to add another one in just because of the way we're eating. And we have to be really disciplined with the eating. And I know parents, you love to feed your kids, I'm sure, and you love to give them, you want to make them happy. But we also want to help them live as long as possible. And by giving them the right foods and by really thinking about it, you can help make that possible. And there's a lot of hope. And in the future for that, just through your diet alone, you can do so much, and you can really help yourself a lot. And so, those are kind of my main things. Like, don't be overwhelmed by it. Just try to make one or two healthy choices to start with and start ramping it up. And, I also understand that there's a lot going on with Duchenne. There's a lot of care involved, and it can be easy to, go for the fast food option and whatnot. But there really are a lot of easy ways to kind of incorporate snacks that aren't as processed. I'm sure Odin and Tiffany have a lot of those little snacks, like, for example, bell pepper and hummus, things like that can be used instead of potato chips or something like that. So I think it's a balance. I think it's not like you can never eat like fast food again. It's just, okay, maybe we don't need to do it like every week. Maybe we could do it once a month, and we can make it a thing. And what I like to do is pretty much every day for lunch, I eat a salad just to get that fiber in, and I have chicken on it just to get that protein in. And that way, like, if, for dinner, I might have like pasta or something like that. At least I've had the fiber earlier in the day, so I can enjoy that a little bit less guilty, you know what I mean? And so it's really kind of figuring out what works for you and your family. And there's so many different options in terms of food and what you can do throughout the day. And so, that's my biggest, thing to you guys is diet is so important. We have all of these medications and things which are great and help us, but if at a baseline what we're eating is not good for us, then what's the point of having all these medications? And so you really want to have a healthy baseline so you can have the most success, so that when we do find a cure, that you're going to be in the best place to receive that. So thank you all for your time.
Thanks so much, Hawken. But what you're saying is actually not just for our Duchenne patient, it's for the family, because what you're describing is really healthy eating. And it isn't imposing a special diet for our patient with Duchenne and our patient on steroids. It really is the healthy diet for the whole family. And then there's little tweaks here and there with the additional, calcium, additional protein. So I encourage all to really support each and everyone in the family to work towards a healthy diet. And I think we oftentimes have seen, actually, we have shrank the parents as well in the past, right? So it works. And I think, as you said, it's in moderation, right? It doesn't mean you don't have your brownie for dessert, But if you're doing well, then you will be eating it, but in the right portion. So it just is applicable to all of us. So we're not going to feel bad that we're going to impose a special diet.
Yeah, and I would say repetition is key. Like it takes like 3 or 4 weeks to build a good habit, and it takes one time to break a good habit. So just keep that in mind. And in terms of meal plan, if you have any questions for me in terms of specifics on what I eat, definitely come up, talk to me. It can feel very overwhelming with everything else that's going on, but if you get this as your base level and you get what you're eating correct, everything else begins to fall into place, and you'll actually have less issues that will need more medication. So just think of it that way, to get your baseline locked and loaded, and then it makes everything else a lot easier in your life. So thank you guys so much.
We made it to 11, but I guess we still have a couple of minutes for a couple of questions, right?
Questions?
Any burning questions?
Yeah. Yes. I see someone in the front there. Yeah.
I was wondering, Tiffany, if you could speak to sodium versus like a Celtic salt that would have the minerals in it for cooking, thanks. So you were talking about high sodium not being great, but what we try to use in the house is Celtic salt or Baja sea salt that has the minerals trapped inside the crystals. And I was wondering if you could speak to kind of the difference between table salt and the other and what you recommend.
Yeah, so as we see, the sodium that is added to food is going to be things like artificial sodium that are more likely to increase things like blood pressure. If we're doing more of those natural-based salt sources, they're also going to come with other minerals in them that are actually going to help balance things like blood sugar. So other fluid volumes, things like potassium in it, magnesium, manganese, all those things that actually don't quite increase the blood pressure like we see in those artificial forms.
Also remember, actually, the additional salt, a lot of our families said, Dr. Wong, I don't put additional salt in my cooking. I don't know where it's coming from. It's the hidden salt in your bread, in your cheese, and in your pasta. These are the 3 highest. And of course, now I add ramen, because I think ramen noodles, a lot of our patients are now taking it. And so I think it's the hidden salt that you're going to look at and look at your labels. So don't beat yourself up with like, oh, I put too much salt in the cooking. And a lot of our patients are drinking Gatorade and Powerade, and that's a lot of sodium, which they didn't know. And so they don't need that. They're not playing football and sweating and losing all that salt. So there is a lot of hidden salt. You just have to look at numbers in all the food that you take. Like tortilla wraps, apparently the flour one has like a lot of salt compared to the corn ones. So I think these little things you learn, and our boys actually learn to look at numbers when they go to grocery shopping. There's one there.
Hello, we are the guys from Chile. So yeah, I wanted to know about the red fruits. You talk a lot about a lot of different things about cure that red fruits could be very good also. So is that true? What do you think on that?
I'm sorry.
Red fruits, strawberries, berries. What is your opinion on berries in general, and any one in particular you recommend more?
Not exactly. When it comes to red fruits, they're gonna, like I mentioned, every color is gonna have its own specific antioxidants. And if you're doing a red-based fruit, most likely you're going to be getting a lot of naturally occurring fibers in it. So again, it's going down to eating the whole food first. So something like a strawberry is actually relatively low in glycemic index because it's a smaller fruit, it has more seeds, it has more flesh to it, so you're going to be balancing your blood sugar a lot better versus like a watermelon. A watermelon is a bigger fruit, it has more sugar in it naturally occurring, so every day eat the strawberries, but if you're going to eat the watermelon like on a weekly basis, just make sure that it's balanced with protein to help support the glycemic control of that food, but they both have really great benefits. Watermelon is also very hydrating as well too, so it has a lot of electrolytes in it. So they both can have really great places within your diet.
Okay, thank you. And
thank you guys.
Creatine, very fast.
Yeah.
What do you think about creatine consumption on regular
Creatine?
basis?
Yeah, so creatine, again, that is something that we've been able to see that helps support motor function, brain function, reduce fatigue. Creatine is one of the most well-studied supplements that we have out there. However, with any supplementation, you want to make sure that you're consulting with your doctor, making sure that you're being monitored, especially when it comes to fluid balance and kidney health. We want to make sure that we take that into consideration. So if we can get creatine from our foods, things like red meats, organ meats, we definitely want to do that first. And if we're doing supplementation after that, make sure you're doing it with your doctor.
Thank you so much.
If you have more questions, feel free to reach out to any of us. Thank you so much.
Everyone.
Thank you. Thanks, Hawken.